Okay, hi. Good morning, everyone. Hello. Welcome to NCIS Winning Against Cancer. It's a beautiful Saturday morning, and you could have been in the park or the beach, but I'm very happy to see everyone here to spend your Saturday morning with us to speak about a very important topic. And for the brain is a very important organ for all of us. It makes us human. It makes us who we are. It gives us intelligence, emotion, and personality. And all of us fear losing these faculties as disease affects this brain. Cancer is not really a topic that we all want to talk about much. It makes us depressed. But I think we must acknowledge that it's real, it happens, and we must seek to understand it better. And that's why we all are here today. So we have 3 speakers today. We are all from the Brain and Spine Cancer Program at NCIS. So we will take you through all the way from the start, how the disease begins, how it's diagnosed, what treatments we can offer, and also how treatment has evolved with time. Okay, so just to get warmed up, maybe we'll start with some questions, and for those participating, we'll give you a goodie bag as well. Okay, let's start with that. Okay, so it's all true or false, very easy. First question: excessive cell phone use leads to brain cancer. Just raise your hand, and we'll pass the mic to you. This gentleman in the front. You just shout the answer. Oh, okay. Yeah, you're absolutely right. So although many people believe that cell phone use, is near the brain, there are a lot of radio waves going on, it can lead to cancer. So far, all the studies that have been done in large populations have not proven that, not even 4G networks and 5G networks. The kind of radio waves that our devices emit are non-ionizing, which means they don't damage our cells, and there's no evidence that it causes cancer. Okay? Second question, brain cancer only affects old people. Oh, everyone, okay. Okay. So that's also true. Also false. Your answer is correct. It does affect old people, but if you see, the statistics, it affects younger people more than old people. Okay, third question. Raise your hands, huh? Okay, don't shout. Brain cancer can start outside the brain. This gentleman here. False, yeah. Your answer is correct. So brain cancer can start outside the body or within the brain itself, and I'll go through some slides on that in a while. Okay, fourth question. All patients with brain cancer have similar symptoms. Yeah, so this lady, false. Okay, that's correct as well. The answer is false. It can lead to varying symptoms, but there are some common symptoms that you look out for, and one of my colleagues, Dr. Arjun, will go through those symptoms. Fifth question. It's scary, right? Brain cancers and brain tumors, but some brain tumors can be cured. True. Yeah, that's correct. So there are different types of brain tumors and brain cancers, and some of them, in fact, majority of the benign ones can be cured. Just to set the stage for the future talks, I wanted to classify how brain tumors are broadly grouped. They can be benign, which means they're not dangerous, they're usually slow growing, or they can be malignant, or what we call brain cancers. And thankfully, majority of brain tumors are actually benign. So it's about a 2/3, 1/3 split. Okay, some examples of benign brain tumors would be things like you heard of meningiomas or vestibular schwannomas. And for brain cancers, malignant brain tumors, there are also 2 different subcategories we can have. Primary brain tumors which start in the brain itself, or secondary brain tumors which start somewhere else but travel up to the brain. And majority, like I said, majority of benign brain tumors can be cured. The risk of developing a malignant brain tumor in the lifetime, thankfully, is quite low. It's less than 1%. Majority are actually sporadic. They can happen just out of chance, but 5% may be genetic or familial related. And in Singapore, thankfully, brain cancers don't feature in the top 10 list if you look at the overall population. But if you look at subgroups of younger patients, it's in the top 5, and of those patients, it's only about 5%. So for brain cancers, we can divide them into metastatic or secondary brain tumors, which start, for example, in the lung or in the brain, and they hop onto our bloodstream, and they travel up to the brain, and they start seeding there. So those are actually more common and make up more than 50% of the cases. If it's primary brain tumors, they usually start within the brain, and common ones that we see on the list would be things like gliomas, or commonly ones are glioblastoma, which is quite aggressive, or pituitary tumors or meningiomas. So for gliomas itself, these are basically cells that support our neurons, and these sometimes can have accelerated reproduction and turn into tumors. And how we classify them is actually based on grades. So unlike other cancers where you have stages of cancer, in primary brain tumors we look at grades, and the grades essentially tells us how aggressive these may be, what are the chances of recurrence. So we have grade 1 to grade 4, and very broadly we classify grade 1 and 2 as lower grade gliomas, and grade 3 and 4 is higher grade gliomas. So for treatment, classically there were only 3 main pillars, be it surgery, that means you remove it surgically, giving it radiation to stop them from growing, or chemotherapy. But in the more recent years, we also have other forms of treatment such as targeted therapy and immunotherapy which have come into the picture. But all of this must be taken in context of the patient itself. We need to consider the patient in front of us. What is their general health? What is their age? What are the other factors we need to consider? And also, what are the patient's preferences? So we need to integrate both of these to come up with a decision for the patient. So coming back to NCIS, this is the NCIS event. So National University Cancer Institute is one of the 2 major cancer centers in Singapore, the other being NCCS. And we are part of the NUHS system. So we take care of the Western cluster, Western population. And we operate both primary care as well as tertiary hospitals such as NUH and Ng Teng Fong. And we also provide cancer care in hospitals such as Tan Tock Seng and Khoo Teck Puat. Okay, before I finish, I just want to give you 3 reasons why you should consider NCIS if you or your loved one needs care. So it all starts with P, it's easy to remember. First is people. So at least in the brain and spine cancer program, we have a dynamic group of individuals who are dedicated to providing cancer care. We all have been internationally trained, and we all have a common goal to get the patient better. Importantly, I think within our institute, there's not much hierarchy. We talk freely between the different specialities to actually get the best outcome for the patient. Okay, so we have an excellent neuropathologist, neuroradiologist, and also expertise such as gamma knife surgeons and awake neurosurgery, which Dr. Teo will be talking about. The second P is process. So we have been doing this for a long time. So since 2008, we have been a cancer institute. So we have processes, workflows, and protocols that we follow for patients. And one of these processes is that we actually discuss every new case at our tumor board where the pathology is reviewed, the radiology is reviewed, and we have a collective wisdom. We discuss among specialties to come up with a plan for the patient. This is not something you may get, in smaller hospitals or in private centers, but within NCIS, we have this regular process of meeting and discussing cases to come up with a plan for the patient. And the last P is personalized care. So we need to take, every patient is different, every cancer is different, and how these 2 interact is also different. So we need to take it in the context of the patient to come up with a plan for the patient, be it standard options or also non-standard options such as clinical trials. So we need to personalize the care that we're recommending for the patient. So having said that, we do have shortcomings, but we take into, we acknowledge these shortcomings and we're willing to change. And clearly, when we want to acquire new equipment and new resources, we need the support of the people around us. So please feel free to make a donation today to help us improve our system and also acquire new technology. Okay, enough from me. So I'll stop here and I'll hand it over to my colleague who will be giving us the next talk about headaches and when you need to be worried about headaches.
Good morning, everyone. Thanks again for joining us on this Saturday morning. It's bright and early, and it's a full room. I didn't quite expect people to wake up at 9 a.m. to come for this talk, but I'm grateful you guys are. So my name is Arjun, and I'm the associate consultant in neurosurgery in NUH. So when I was first asked to talk on this forum, I wasn't really given a topic, and was asked to choose. And it was actually my wife who came up with the idea. I asked her, what do you think people would like to know about, if topics such as your brain matters in a context of a cancer forum? And I guess what we came up with was, how best to sort of identify when you think you need more help. It doesn't mean that every time you have a headache, it's a brain tumor. Okay, that's the message I want to hope you guys take away from my talk, is that just sort of keep an eye, know that headaches are happen, and there are various causes, but not all headaches equate to something serious. So in order to be, headache is a huge topic, and in order to be, trying to cover all grounds, I will have to talk about non-tumor headaches first. And because these are the more common ones, these are the ones that affect us on a daily basis. Yeah. So the first bit of headache. So in my order, I tried to categorize this talk with the most common headaches first. So the non-neurosurgical kind. So how common are they really? So headaches are one of the more common common health complaints globally, with an estimated 50% of adults experiencing this. The tension type headaches, the ones that we experience on a regular basis, these are the more common type. And generally, they tend to be a diffuse band-like headache. So it covers the entire head, and you feel like as if something is constricting you. And the key thing about these headaches is that they don't come on suddenly. They sort of slowly develop over a period of time. And I'm sure you've heard a lot of people say, "Oh, I'm having a migraine," or something like that, right? So a migraine is actually a very specific sort of headache syndrome. It tends to be familial, meaning it tends to run in the family sometimes. And it's quite characteristically on one side of the head. It's a very throbbing sort of feeling. Sometimes it's associated with things like visual disturbances or vomiting even. And it's quite a wide sort of very presentation. And it is important to actually seek help if you do develop these symptoms, mainly to make the diagnosis and also to make sure that you're not dealing with something a bit more serious. Cluster headaches is the other more common variety, but again, it is much less common than both tension and migraine types. Generally, is also one side of the face, one side of the head, associated with a bit of tearing and a bit of a nasal discharge. And then there are also other types of headaches. It generally affects a bit more of the face, such as trigeminal neuralgia or temporal arthritis. Again, these are much less common. And then as we go down, as we scrape the bottom of the barrel, there are also other things that can cause headaches, such as anxiety, depression. All these things can also contribute to headaches. So what differentiates these headaches? And the most important thing I would say is actually these factors that I put up. Basically, is the onset, frequency, duration, and the severity. And one of the other things that's also very important is any other symptoms that accompany the headaches. So now we go on to the neurosurgical kind of headaches. So before we do that, let's find out why, what's the anatomy of a headache? Why do you actually have a headache? What actually processes these pain symptoms that you're experiencing? So in general, it's quite simple actually. This one is basically there are 12 cranial nerves in the brain. All of them supply different function of the brain, of the face, and also of some of our organs. And the sensation in our face as well as the head is all supplied by the cranial nerve 5, which is a trigeminal nerve. And this is actually the division of how it is distributed. And the pain sensitive areas are actually your scalp, muscles, eyes, mucous membranes, arteries, vein, and dura. Dura refers to the covering of the brain. And so it's very important to note here is that the brain itself does not experience any pain. And this is very important in the next talk that you're going to hear that Dr. Teo is going to give. So again, before we go on to the crux of the matter, I'm just going to talk briefly about the vascular variety of headaches, which are again much more common than your tumor type of headaches. So intracranial hemorrhage, often described as the worst headache of your life, as if someone you're fine 1 second and then the next second you feel someone's bashed you on the head with a hammer. It comes on suddenly, comes on unexpected, and it has no real pattern when it comes on. This is something I would say the one thing that you'd have to kind of look out for in order to seek medical help as soon as possible. And often these headaches are also associated with vomiting, weakness of arms and legs, and of course in severe cases, that you can have a sudden onset headache and then, quickly slip into like unconsciousness. So just to show you a couple of slides on what I'm talking about. So this is a CT scan of the head, and then what we're looking at is basically a hypertensive hemorrhage. So this patient also presented with quite a severe headache, and but at the same time, given the size of this clot, he also had weakness of the arm and leg. So what can we do with when patients present with something like this? We can oftentimes actually have to do surgery. And this probably involves a small opening in the skull, and then we evacuate the clot. And patients can actually recover in terms of their conscious state, and it's actually a life-saving procedure we sometimes do. This is the other variety of vascular causes of headache, and this is called what we call a subarachnoid hemorrhage. Again, the CT scan of the head, as you can see this white pattern, the star-shaped pattern that you see on the scan, that is actually the distribution of the blood. And this is a cartoon of where the blood is distributed. And this is generally due to something called brain aneurysms. I'm not sure if you've heard of it, but basically brain aneurysms refer to abnormality in the vessel wall, where there is a little weakness in the vessel wall. It develops into a little balloon. And these things by themselves don't cause any symptoms until they rupture. And then they present as very severe headaches. And again, this is one of the reasons to seek medical help if you were to suddenly develop a sudden onset headache. So how do we treat these brain aneurysms? So we can do it in two ways. So this is an example of an angiogram where you can see the brain aneurysm. And then one way of treating it is through coiling, where we do it where we run some lines up one of the big blood vessels in the body, and then deploy coils, block off the weakness in the vessel wall, preventing it from rupturing again. And this is the post-op result. As you can see, the aneurysm is completely excluded from the circulation. And the other way we kind of do this is actually through traditional surgery, where we open up the head, find the aneurysm, and literally put a clip on it. Just a short video of how we do this. And then once again, we do the same thing. We kind of exclude it from the circulation. Okay, so now we've just covered firstly the non-neurosurgical type of headaches, which is the most common type of headaches, and then we've covered the second most common would be things that you need to seek urgent medical help for, so the vascular variety. And then now we're just going to get to the crux of the matter, which is headaches that are related to brain tumors. So, as you know, headaches can be symptoms of brain tumors. And again, like I said, what I would like you to take away is really when to identify or when to keep a lookout for and when to seek help. So as what Dr. Bala has earlier covered, generally brain tumors are divided into malignant and benign, primary and secondary, So there are various classification systems, and the way each of these tumors sort of develop, cause symptoms, all depends on various factors which we'll be going through right now. The most important thing is location, location, location. So brain tumors can arise in various parts of the brain, but the way they cause symptoms, the way they present, all depends on where they are located. The headaches from brain tumors in general are from the stretch that the covering of the brain experiences as the tumor expands. So that means small tumors in general will not have any symptoms. Large tumors reach that size because they actually grow very slowly, and because they grow very slowly, the patient themselves may not really notice anything too wrong over the months and years that it takes for this tumor to grow in size. And this is where it differs from the vascular sort, where you have a sudden expansion of a blood clot in the brain, causing sudden expansion of the covering of the brain, and then this is why you have a sudden onset headache. And again, the other key differential factor, whether it's benign or metastatic, is important because the speed of growth is different for benign and metastatic, or benign and malignant. And because benign tumors take their time to grow, they tend to present later, they tend to present larger. Whereas tumors that tend to grow faster present earlier because of their rate of growth. So, we're talking a bit of metastatic tumors, which is basically what that refers to is tumors that have arisen from outside the brain and have spread to the brain. And these, by very definition, means that they are malignant. And these tumors can be persistent, they gradually worsen with time, and because of the amount of, as this scan actually shows, I'm sure you can all see the abnormality on the scan, but what you're seeing on the right image, where there's a lot of white discoloration on the brain surrounding the center black area, all that is just swelling. It doesn't actually involve, it's not actually tumor per se. So this tumor is causing headaches by causing swelling of the surrounding brain, stretching out the brain, and then stretching out the covering of the brain, and hence you're having these headaches. And these headaches tend to be worse in the morning. And this is just the physiology of how our body works. And in this particular case, location is important because this patient not only presented with headaches, but also presented with a weakness of the arm and leg, again by the nature of where this tumor is located. And sometimes these tumors can be multiple, like in this case. So this is a scan, different cuts of the same patient. It shows multiple tumors, but this patient is fairly asymptomatic from this. He doesn't really have much symptoms. This was picked up incidentally. So you can see that you can have multiple tumors but not have much of a symptom as well. So the other big group of malignant tumors in the brain are primary tumors, which are called gliomas. And these tend to have, again, headaches. They tend to be long-standing. Some of them tend to be slow-growing, so you may have like 6 months of symptoms before you finally decide to seek medical help. And sometimes, by the virtue of their location, they can be associated with things like speech abnormalities, personality changes. So this particular patient was a young patient who had, again, 6 months of headaches with personality change, speech issues. And I'm not going to dwell too much into this because my colleague, Dr. Teo, is going to speak about this in the next talk. And the next big section is the benign tumors in the brain. So as mentioned earlier, these tend to grow slowly. And because they tend to grow slowly, they tend to present at a much larger size. And in this particular patient, because again of the location of where of the tumor is, she presented with headaches, weakness of the arm and leg, as well as seizures. But the good thing about these tumors is that because they are benign, because they are located on the surface of the brain, they're relatively easy to remove. And actually, after good surgery, it's considered a complete cure. And then again, a different part of the brain where patients present differently is where we call the sella, which is actually the center part of the brain. And the key thing about these kind of tumors is that they tend to present very close to where the eye nerves run. So these patients sometimes have headaches, but more importantly, what they have is visual disturbances where they find that their peripheral vision, the vision on the sides, tend to be affected more along with these headaches. But again, these tend to be benign, tend to be slow growing. And the good thing is with good surgery, and in this particular case, we can access this tumor without even opening up the scalp. And we can access the tumor to the nose, and we can again effect a complete cure and actually restore the vision in these patients. The same sort of tumor sometimes tends to present suddenly, like a vascular event. It's a sudden onset sort of picture, because these tumors sometimes they grow to such a large size. They sort of bleed internally and then cause sudden expansion again of the dural covering, as we talked about earlier. And then they also present like a sudden onset symptom, but actually it's from a brain tumor. Just to be comprehensive, not all these tumors need surgery. Some need surgery, but some of them can actually be tackled with medications. And it's a special group of tumors called prolactinomas, where taking a tablet a day just sort of shrinks the tumor away. And then another big group of tumors, again, this is a group of tumors that tend to grow near the brainstem, a very critical area of the brain. And they tend to cause symptoms in a very specific manner because they block the flow of the brain and spinal fluid that is naturally circulating the brain and spine. And then they tend to cause headaches, early morning headaches. They tend to cause gait instability. So not only are you suffering from, say, 6 months of progressively worsening headaches, you also tend to find that your balance is off, your coordination is not so good. And then again, as you can see, what I mean by blocking of the ventricle size, you can see those are the black structures in this scan. You can see that they're a bit dilated, and this is all due to the fact that the tumor has blocked the flow of water. So this is just a short video of how we take out these tumors, which is essentially access the tumor, we cauterize the surface of the tumor. We use this special device called the ultrasonic aspirator, where we make a small hole within the tumor, decompress it from within, and then once we've decompressed it enough, we sort of peel it away from the critical structures of the brain. And then this process is carried on for several hours until we get a nice clean result. And as you can see also that the ventricles that were a bit enlarged at the beginning of the before the surgery, they are now returned to normal size, and the patient's headaches and symptoms have also improved. So we've covered very broadly on the various headache phenomena that you can experience, whether they are from benign conditions, were not related to anything too serious, or something like vascular or even brain tumors. What can we do about it? So again, not the scope of my topic, but briefly, we can give some medications such as steroids. These tend to address the swelling, and this does help with the symptoms, but these are not a long-term sort of solution for brain tumors. Chemotherapy such as Avastin and temozolomide. We also have radiation treatment such as whole brain radiotherapy, fractionated radiotherapy, and gamma knife radiosurgery. And because I'm coming from a neurosurgical perspective, I've spoken a bit more about open surgery and as well as surgery through the nose, and my colleague will be speaking about awake surgery in a short while. So in conclusion, I would say don't panic. Brain tumors are relatively rare. If you're having a headache, in all likelihood, it is probably something to do with your lack of sleep, or you've had too much to drink the night before, or one of those things. Not all headaches are brain tumors. The vast majority are benign. And if you are someone who is experiencing headaches, look out for the QT, look out for the pattern. So you can see, this is just an infographic of how you can sort of identify various types of headaches. So your thunderclap headache, this is the one we talked about. This is something you need to seek medical help urgently. Migraines tend to be episodic. And the last one, you can see that the intracranial lesions, these brain tumors tend to develop over time. And also very important to remember any associated symptoms that come along with these headaches that kind of tell you whether you should seek medical help.
I'm Kurtia. I'm a neurosurgeon and I operate on brain tumors. And today I'll be talking to everyone about a relatively scary topic on doing brain surgery with you awake. How's that possible? Yeah. So I'm just going to keep it really lighthearted. If you have any questions, you can shout. I can leave it to the end of the talk. So I'll be pointing here. So if you cannot see it, let me know and I'll go there and I'll point at the screen there for you. Okay? Okay, so I'll begin now. So I think my previous colleagues have spoken about this. I'll just jump through these slides on how common brain tumor is. But what's important, after what we spoke about, meningiomas, gliomas, all the do you know where they come from? So I'm going to give a really quick anatomy lesson, free of charge to everyone, on how the anatomy of the brain is like. So very simply, our brain is like tofu, and it's being covered by a plastic bag. So that's how you imagine. In that plastic bag, this plastic bag, no need to pay 5 cents on. It's free. Everybody has this plastic bag. And in this plastic bag, there's water, and the brain is inside this water. Okay, because the brain floats on water. And based on this, so if you can look at this, sorry about the guys, that's bone. Underneath the scalp is bone. And all this thing called dura is the plastic bag. And underneath that is already the brain. Why is it important to tell everyone this? Because tumor can arise from any of these structures. Can come from the scalp, can come from the plastic bag, the dura, can come from the brain, can come from the blood vessel, can come from everything. So that's why there are many different types of brain tumors around. And that's why Dr. Arjun spoke about, and Dr. Bala spoke about meningiomas, which come from the plastic bag, the dura, gliomas, which come from the brain itself, neuroma comes from the nerve. So these are examples of where all the brain tumors come from, different various parts of the brain. And our brain has different functions, so that's why you have different symptoms. So like what my past two friends have spoke about is different types of brain tumors. The most common type of brain cancer is not brain tumor. I get asked a lot about this. Cancer is cancer. No? Tumor can be cancer, can be benign. The most common brain cancer is those that spread from elsewhere. Breast cancer, stomach, lung cancer spread to the brain. You watch those shows, oh, we're going to die in 2 weeks or something. It's not true. But anyway, what's true is they spread to the brain. And that's the most common one. The not as common one are those that come from the brain itself, which is what I'm going to talk about as well. And within that, they come from the dura or within the brain glioma. So just some very quick statistics, which I'm going to quickly say. Most of them, like what Dr. Bala said, they are benign. Males, females, depending on the brain tumor, more or less equal. And the most common non-cancerous, the benign brain tumors are meningiomas, primary brain tumors. And for the brain cancers, primary brain cancers are glioblastomas, which unfortunately doesn't matter where you're from, what race you are, what religion you are, the outcome is still very poor, unfortunately. And this is what we are trying to fight this disease. Okay, so the survival in general is about 2 years, based on this paper as well. So what are the symptoms? I'll quickly go through this, which Dr. Arjun has very detailedly spoken about headaches. I'll skip that. But what I'm going to speak about is other symptoms, So most of the time when you start having headaches from a brain tumor or cancer, it's pretty late. Because our brain is actually very, very intelligent, depending on where the tumor is. So once you have a lesion pressing on an area, for example, which controls the hand, you start having hand problems. And it's very subtle. Imagine it's your left hand. I use my right hand to play my iPhone. I use my right hand to drive. You seldom use your left hand. So some things we ignore, you see. The left hand to pick up our cup or to play our iPhone. And sometimes some people get things like seizures. So generally, in general, when you have a seizure when you're 20 and above, it's not common, And when you have that, you should seek help straight away and get some screening done. Normally with little babies, they have fever and they have fits. That's relatively common, but you still should seek help. But once you're an adult and you start having things like this, you should get a screening scan done. So I'll go straight to management. How do we manage brain tumors and brain cancers? So like what Dr. Bala said, it's a team approach. Every team member has a role, whether it's a surgeon, the oncologist, the radiation oncologist. We work together, and this day and age is not a one-man show anymore. So even after we remove the tumors, they still need to have some form of chemotherapy, some form of radiotherapy. And you can't give radiotherapy if there's so much tumor left there, because you need to give very high dose radiation. So we all work hand in hand and we discuss cases to how to best manage our patients. So now I talk about the topic, what is awake brain surgery? So this is what I find in literature. I Google search it. Although I give a talk, I don't know how to say it. So it's actually called awake craniotomy. So it's performed when you're awake. It's like Wikipedia. Procedure where patients are awakened during surgery, which is true. And why we do this so we can preserve functions. Okay, which I'll elaborate further. So in the past, actually awake surgery is not something new. So this is long ago, awake surgery was done, but that's not by choice. Awake surgery was done then by 5 gladiators pinning you down, and somebody used a tool like this to drill a hole in your head to remove blood clot, to remove evil spirits and demons in your brain. Thankfully, we have evolved, and since time progressed, we have this was one of the first few awake surgeries done. It's done for epilepsy, for seizures, 羊癫疯, seizure. So when patients have seizures, they can monitor this and they start removing things that cause the seizure, and that's how it's done in the past. So actually, if you look at all these old images, they're more or less about the same, except now we've got color definition and we've got better technology. And so all these soon went to Hollywood as well, and even to the Korean dramas. And when I was watching it, it's actually quite accurate, or how they depict awake surgery. It's not bad, but the only problem is I don't look like them. I wish I did, but I don't look like them. Yeah. So, what do we do awake surgeries for? Okay. We do awake surgeries mainly for brain tumors, like depending on the location of the tumor, and some non-tumor stuff like AVMs, vascular malformations. And also basically, in summary, the purpose of doing awake surgery is to go in and take that thing out and to preserve your function. We don't want to go in, anyone can go in and put their hand in and take out a tumor, but if you look at the patient, they will have some problems, and these are the problems we are trying to preserve, We don't want them to have problems. Now, back to anatomy again. So this is just a cartoon diagram of how our brain functions. So the colored areas show you in general what the function is. So the yellow area is for movement, the green area is for making decisions, and so forth. But in reality, when I operate on the brain, there's no color for me. It's all like this. Okay, and to make it even more complicated, within one, like a walnut, right? One wrinkle, different parts of the wrinkle got different function, So if I look at the bottom part of the walnut, controls me talking, As you go higher, it controls my legs, So within one wrinkle, there's so many functions. One wrong move, and this violin player cannot use her right thumb. Every finger is important. And that's these are things that we need to monitor. And that's only the outside of the brain. How about the inside? Most of the time, tumors are located inside. So all these it's just a cartoon diagram again. I always start with cartoon diagrams. These are like roads that connect one part of the brain to another part. These are what we call white matter tracks. That's how one part of the brain communicate with another part. It's like telephone wires, So in general, this is something very familiar which all of us know. It looks like this. How, Bedok communicate with West Coast, something like this. But it's not so simple. Actually, it's more like this. And everyone's connected. So we need to be careful. We need to be very careful of which one we can preserve. And don't be a terrorist and bomb one area, and after that, we got a problem, So this is a cartoon diagram of how a tumor can involve our roads, the tracks. They can push it to one side, which is good. I can remove it. It can involve a bit of it. Can I sacrifice a bit of the AYE? Yeah, maybe can, and the road can still travel, no jam. But if the whole road is blocked, we're going to have a problem. And that's how doing awake surgery helps me identify this. One of the concepts for awake surgery is what we call neuroplasticity. And that's what I tell all my patients. So don't give up. So our brain has this amazing ability to recover through rehabilitation. So if you keep training your brain, and that's the only muscle, regardless of age, you can still train it. Of course, if you're 75 or 80, it's slower, but it's still there. It's not gone, it's still there. If you train your brain can recover. They can form new AYE, new ECP. It can form all these new things. So how does this tie in with awake surgery? So when there's a tumor that disrupts one of the AYE, and if I remove it, you can start building new roads in your brain, and you can recover from the surgery. And if your tumor comes back, we can go back in again and take it away because you are forming new networks in your brain. The next video I'm going to show you is a violin player. So one of my patients who after surgery, she couldn't move one side of her body because I caused that. Because I know that she will recover. And we did rehabilitation for her. How do I play this? So you see, this is the second week of surgery. She only could move her leg. And within 5 weeks, she was already moving her hand. That's through aggressive rehabilitation. She took this video and she sent it to me. So after 3 months, she could do this already. And in the third month, she's putting a thread to the needle hole. I can't do this. She's doing this. So she just bear in mind 3 months ago, she was lying in bed with diapers. Okay, I think I can skip. It's very long. I bet she's playing cards. So how do we do awake surgery? So first, it's not that you want to do, we just send you to the clinic to do it. Most of the time we do a screening in the clinic. We get a history done. We get certain scans done if needed. And we get a neuropsychologist to see you. So she's very important, I'll explain later. And after that, we get an anesthesia to make sure you're even fit to go for surgery, physically fit. This is an example of some scans we do. On the left-hand side, you can see there's a yellow, can you all see there's a yellow dot there next to a white tumor? So basically, the white thing is a tumor. The yellow dot, the yellow ball is the one that tells you where this thing controls her arms. So you can see how close a tumor is the area which next to the area which controls her hands. So one wrong move, she cannot move her hand for life. And if you look to the right-hand side of the screen, those blue things, those are tracks. The roads, the real life road. And you can see how the tumor, the black thing is pushing the tumor to one side. So this tumor has to be taken out to preserve the yellow thing outside, and the inside is to preserve the purple thing. So this is an example of how imaging works. And I'll go straight to a neuropsychologist who sees every of our patient before they go for surgery. So she does what we call a neurocognitive assessment. A neurocognitive assessment is something which we neglect. Excuse me. She assesses your capacity, your memory, your executive functioning, your emotions, your dexterity, your attention span. So why are these important? You ask. Those are important because these are things we take for granted as we function as a human being, you know. And so after this test, we will look at the scores, and we need to see what is deficient, what the tumor has caused a deficiency in your neurocognitive state. So a tumor can cause problems in this. And we will decide whether can this be brought back after surgery. Has a tumor destroyed this? And we monitor whether neurocognitively, whether have they made any improvement. And not only that, she also sees, because we all know that having a brain tumor, there's a significant amount of psychosocial distress. And this is something which we are trying to bring awareness to every year. These stresses could be due to physical symptoms, functional impairment because of the tumor, or from the surgery, side effects of therapy, and this uncertainty when you have a brain tumor. And so this will be addressed by our neuropsychologists as well. So she will screen for any unmet needs and distress, and some form of psychosocial support will be provided by her and to help cope with illness. So you know why a psychologist is very important in our team when we see somebody with a brain tumor, because we cannot ignore this psychosocial aspect of the disease. So this awake surgery is not suitable for everyone. Through the neuropsychologist, we identify those who have unfortunately very severe deficits, and they can't perform any tests during the surgery. Sometimes they are emotionally not ready, and sometimes they are anxious, and that's when we try to either help them pull through and see whether can they really do it, or if it's too dangerous to proceed with someone like this, we do not do such surgery like this, because safety comes first. And our anesthetists will rule out other forms of physical problems. Like if you are too obese, obesity is a problem because you have an airway problem. You can't breathe properly during surgery, let alone speak and everything during surgery. And of course, people who are too young, they can't go for such surgery. So these are the physical aspects of why we can't perform awake surgery. This is how the operating theatre look like. Don't look like Korean drama. It looks like Pasar Malam. Everyone is crowding around. You can see there's a lot of machines, at least 8 to 10 of us sitting inside the room. And the patient, him or herself becomes a member of the surgical team. I'm just going to show some operative videos over the next few slides. If you find it a bit too gory, just close your eyes. I'll just be very fast with it, all right? So this is how it looks like. So the top picture over there on the top left is how a patient is lying. It looks very cruel, but actually it's very comfortable. His head is being held by a construct. There's is anesthesia there. He's lying on this air foam mattress. I lied on it myself. It's very comfortable. Keeps you warm as well. And those are the other equipments we use. There's a little tent where you can see there's somebody in green. So that's our neuropsychologist talking to the patient, assuring the patient, and teaching him or her what to do during the surgery as I take out the tumor. These are the tools I use. In general, it's like one pair of chopsticks. Okay, so what these chopsticks do is it passes electrical currents on the brain. Like what Dr. Arjun mentioned earlier, the brain itself has got no pain receptors. What the electrical current does is it passes a current to stun the neurons, the nerve cells. So if I ask you to perform something and if I pass electrical current there, you got no reaction, I can take the tumor out there. If you are doing something and I pass the current, suddenly your hand drops, there's a problem, That means this area of the brain is important. We can't touch the area. So this is just an example of how we do it. And this is how it looks like in real life. It looks like chopsticks, right? But it's more expensive than a chopstick. And so this is an example of how we stimulate the brain. And besides that, we also have a computer that's connected to the patient, which also tells us whether is there any contraction of the muscles. Because sometimes patients, they get too tired. We're not sure whether are they really working or not. And this is like an insurance for me, just to know whether are the muscles firing, is the patient awake. So these are electrical currents that are being passed. And then we wake the patient up, and then we test certain functions. And we put those little numbers on the brain, you can see. Those numbers on the brain tells me that the area of the brain cannot be touched as function. So each number represents something. It could be speaking in Mandarin, speaking in English, naming sentence generation, hand movement, finger tapping. So there are different things we test for depending on the location of the tumor. Sorry about this photo, but this is a real life photo. On the left-hand side of the photo is before I take the tumor out. All the numbers are the areas which you cannot touch. And on the right-hand side of the screen is I've taken out the tumor and I preserved this function, so I'm very sure she will recover. Because she's real life, she's moving in front of me and everything. Okay, so this I'll quickly, sorry about the photo. So what do we test for? So this is just an example of gross motor testing, which I spoke to you about. So you see, this is just an example of movement that we test. Very basic hand movement. However, we are not, as humans, we don't do this every day, right? I open my car, I open my door, I write things, I use my laptop. So these are things that, as primates don't do that, humans do that. So by doing this doesn't mean I can put a key in a keyhole. And so this is what we test as well. So we call motor cognition. Motor cognition. So when you give any human being a key, you show them a keyhole, they know how to put it in, they know how to turn. So these are things we test for. And dexterity. Okay. So this is even one level higher. We test this on some patients. I want to show you this photo. You see, she's turning a doorknob. And you can see as I'm passing currents to the brain, she'll stop in a while. There. You see? You see her stopping? That's caused by me. So I know the area of the brain we cannot touch because it involves a motor cognitive, it's called a motor cognitive tract. Okay, so these are examples of the things we do. And I'll quickly move on to language. We also test languages, and language is actually a very complex thing, because things, we need to listen, process, and speak out. Very basically, but speaking is more difficult than that. You need to make sentence. You need to do action naming, use verbs. All those need a lot of processing. This is just a very simple level 1 way of testing, naming. So the patient will say this is an elephant. Okay, this is a tiger. This is a dog. This is a car. So when there's a naming problem, when I'm stimulating the brain, she will say this is a. She can't name. So this is how we test a naming problem. If she has a speech generation problem, she can't even say this is a. She will. So that's how we identify things like this. But unfortunately, once again, it doesn't end there. It's more complicated than this because we're all Singaporeans, we're multiracial, multicultural. So got headache, cannot just do English. Who only speaks English? No, we speak English. And there's also Mandarin, there's also Tamil, there's also Hindi, there's Malay. So we have to adapt and we have to come up with our own tasks for every Singaporean here that can make sure that we can still speak our Singlish at the end, can still speak our Malay, Hindi, Tamil. So we came up with a deck of slides for various languages as well. I want to show you. So he's speaking English. I think it's a bit soft, but I can listen to the next one. So he's speaking in Mandarin. He's doing naming tasks. So the first one is actually English. He's saying this is a dog, this is a cat. And after that, we do switching to this is a 这是巴士 or things like this. And that's how we do. We test during surgery. We need to preserve at least 2 languages. And on top of speaking and moving, we need to think as human beings. Okay, so what are things that we also try to preserve? Executive functioning. I need to think, tonight where am I going to eat? Tomorrow where am I going to go? When I go to NTUC, what's 5 plus 2? You know? How much change I got? Okay, now it's all paywave, but things like this that makes us humans, you know. So there's this test that we do. It's called a Stroop test. It's validated. You all can try. You're supposed to name the color, but not say the word. So the first one is red, second one is green, third one is blue. So, and there's a 4 seconds, so you must do it within 4 seconds. I tried it, I failed at first. I thought, is that a problem with me? So, so that's why the neuropsychologist is supposed to teach you and train you. So it's like doing PSLE, you know. You can't just go and do PSLE like that. You do 10-year series, you know. So that's what the neuropsychologist does. She'll train you. So any mistake you made that day, it's not because you're stressed or you know, you never do it before, but because a true error that's done. And the one below is for our Mandarin, like we have different languages as well. Okay. So this is how we test decision making for our brain, how it makes decisions. And also, one thing that was also being neglected in the past, I'm sure you have seen people who had brain surgery before or any form of brain procedure done. They're okay. They can look at you, they can smile, they can do this, they can talk, but they're just not the same anymore. Just a bit different. Like, some people, they said my wife's a bit different, a bit quieter, which is good, but I don't know why. She's don't scold me as much and everything, you know. But we realize there's a problem. So we realize what happens is they got some emotional problems. So a bit like zombie, they can't recognize emotions. They don't have as much emotions as before. So that's what we test as well. Something that makes us uniquely humans, you know, emotions. How do we recognize emotions? So there's this test that is being validated and done, and which we do as well, is to recognize emotions as we take out tumor to preserve the emotions aspect of our brain. Which some people don't care. They say, just take out my tumor, I don't care about it. But actually, this is what makes us humans, you know, how we have human interaction. And how we do it in Singapore is this test, you know. So you're supposed to look at the person's eyes, and you're supposed to tell us the emotions. So is this called reading the mind in the eye? So you know what's the first one? Is she jealous or is she panicking? Oh, really? You don't know? Yeah, correct. She's panicking. Yeah. And then the next one, she's correct. She don't look like terrified, right? So these are just very simple. Actually, we have a lot of those. But we test these on patients, because and that's how we preserve emotions on patients. So the original test actually was done for Caucasian eyes, and actually a lot of people failed it, and that's why we changed it to Asian eyes. So this I tried it, I failed. I won a 0.25. Not that I'm emotionless, but I think it's just the Caucasian and Asian eyes. But then we changed it to the Asian eyes. You try everything. Korean eyes, Japanese off, but she's Singaporean. So this is our old paper, which we did 76 papers. I'll just skip this. So is awake surgery acceptable? So when I first started doing this 5 years ago, a lot of people said this is very brutal. How can you go open someone's head is awake? So I had a lot of comments on this. So I went to do a study, you know. I went to ask around all the patients I operated on what they feel about this procedure. And now this new generation, everybody do their research on YouTube, Wikipedia, WebMD. You know. And everyone's actually coming, they're pretty well prepared. And thanks to Hollywood and K-drama, it's quite accurate. They all come prepared and they know what it is. And during surgery, they do not have much discomfort. They're okay. A bit of discomfort, a bit of fear. The aircon is cold, but they're otherwise okay. And what's comforting is 83% of them don't mind going and do it again, you know. This is not Disneyland, you know. It's not like go again. But why is this important to me? It's important because sometimes when a tumor comes back 5 years later, you at least you give me a chance to take it out again, so you don't have to succumb to the disease. And this is important because if you have a bad experience, you won't want to do it again, and then you're just gonna passed on from the disease. So this is important to us. So it's not as bad as what we think it is. And now with that, I'll end this talk. This is more of a patient who's given consent. She's actually had her brain open. We have to remove her tumor, and she wants this photo to show everyone. She's a very brave lady.
So yeah, thanks for the talk, Kocha. It's very insightful, very nice examples. I think it's come a long way. Surgery has evolved with time, but along with surgery, there are also other treatments which have also evolved with time. So from something that is invasive, we're going to be talking about something that's non-invasive, and that's about radiation therapy. So I've titled it Healing Rays because it's got some healing properties, but I want to be a bit more balanced. I want to also talk about the downsides of radiation therapy and what we can do to mitigate some of these side effects. So this is what I hope to cover in the next 20 minutes. So I'll be the first to say that radiation has got a bad reputation in society because of all that they've gone through in history with the atomic bomb, with the nuclear plant disasters and things like that. Okay, so we know that it can affect people in a bad way. However, if we control the way we use radiation, it can be beneficial. Just like we use a magnifying glass and we control the sun's rays, it can be used in a beneficial way. So for brain radiotherapy, it features, like we talked in the past, there are a few ways that we can use to treat brain cancers and brain tumors, be it surgery, which is removing it surgically, like what Dr. Teo shared, or using X-ray treatment or particle therapies to treat these brain tumors, or chemotherapy. And there are multiple guidelines which support, over the last 30, 40, 50 years, we have come up with enough evidence to suggest that it is beneficial in a number of conditions. Okay, so for most brain cancers, usually surgery and radiotherapy feature more in the treatment, particularly because there is a lining around the brain, similar to the plastic bag that Kocha talked about. There's something called a blood-brain barrier, which it's a protective mechanism that our brain has that limits the kind of things that go into our brain. So usual medications like chemotherapy that is used for other types of cancers, they cannot penetrate the brain so well. So chemotherapy does not feature very much in certain types of brain cancers, especially metastatic tumors. Okay, how many of you have heard of DNA? Okay, I see some hands. So why is DNA important? So DNA is basically the code book that our cells rely on to replicate. So they need this coding to actually produce daughter cells. And how radiotherapy works is that it damages these DNA strands. By causing breaks in the DNA, we prohibit or stop the cells from dividing. And how this works is basically there's energy that is passed through these cells and the DNA breaks. But to those in the audience are wondering, won't my normal cells also be affected by these same radiation that you're using to target the cancer cells? The answer is yes, but thankfully our normal cells have better repair capacity. They can repair the damage that they potentially may get as we use radiation. And they can actually go through repair and as well as replication from there. So, and also to add on to what Kocha said, surgery is a very important treatment. That's usually what we start with, and that takes out bulk of the tumor. But many studies have shown that, especially for gliomas, which are infiltrating, that means we have tentacles that go beyond what we see on the scans, as well as intraoperatively. And these tentacles have cells which can subsequently lead to relapse and recurrences down the road. And where radiation comes in is that we usually, after surgery, we try to sterilize the remaining cells that may be in the vicinity to actually delay the chance of relapse and reduce the risk of recurrence. So we actually learned about how to use radiation, if you believe it, actually from French farmers in the 1920s. So these farmers actually used radiation to sterilize their ram. They didn't want their ram to replicate, to produce more progeny. So what they did is that they gave this radiation in a single session to the testicles. And what they found was that by doing that, giving it in a single session, there's actually a lot of side effects that the ram were getting. They were getting a lot of skin reaction. So they repeated the same experiment, but they did the radiation in smaller sessions, and they achieved sterility for the rams, but no side effects. And that's why fractionation, that means when we give the treatment, we divide it into smaller sessions of treatment in order to sterilize the tumor, but also reduce the side effects for the patient. And that is also because normal cells repair themselves as we're doing this fractionation. And radiotherapy is basically like intense light. Only where we give it to, that has an effect on the tumor. It's a very focal treatment. And there are various ways we can actually deliver this treatment. So what we see here is modern linear accelerators. So these are machines which produces high energy X-rays, which is focused on the tumor. What you see in the center is what we call the gamma knife. It also uses high energy beams to focus these beams to parts of the patient's brain. So it's called what we call radiosurgery, but it's not invasive. We don't need the scalpel to do this treatment. Okay? And just like how surgery has evolved all the way from the gladiators to where we are now, radiation has also evolved. So in the past, we just use a few beams of radiation. And although we can hit the target pretty well, we can see a lot of spillage dose that goes to the surrounding areas. As you see in this color wash, the areas in blue is what we can try to reduce side effects of the patient. And over the years, we can actually home in on the tumor a bit better and spare the normal parts of the brain even more. But radiotherapy is a complicated process. It takes many steps before we get to the final plan. And this involves the patient being immobilized, as you see in this picture on the left, in a fixed position that we can replicate day on day as they come back. Once they are immobilized, we get advanced imaging to localize where the tumor is, as well as to where we can spare. And also we have radiotherapy planning, so to plan the treatment to make sure that the radiation beam homes into the tumor. And we also have image verification as the patient is undergoing treatment. And image verification has evolved over the years as well. Previously, we just relied on two-dimensional imaging, just taking X-rays, which are not very clear, but we know it's somewhere there. But thankfully, now we can actually do three-dimensional imaging like CT scans and MRIs while the patient is on the treatment table to actually be within a millimeter of accuracy. Yeah, so just like how surgery requires many people in the operation theatre, radiotherapy as well is not a one-man show. We have many people working behind the scenes to make it a successful treatment. And they may be radiation therapists, dosimetrists who plan the treatment, medical physicists, as well as radiation nurses and a whole team of doctors working for the patient. So if I can just elaborate, you may have heard of Gray, those of you who have had relatives who have undergone radiation. It's measured by a unit called Gray, and it's actually a spectrum of what we can deliver, and that depends on the intent of what we want to do for the patient. So it's like when you roast beef or roast meat, if you put it longer on the cooker, it's going to be more well cooked. If you just put it on for a short while, it's going to be rare or medium rare. So if you just try to alleviate symptoms, we don't want to cause too much problems for the patients, we use a lower range of the spectrum. Whereas if our intent is to cure the patient, we have to take it up to a higher notch, but at the same time, we have to also balance side effects that can come with this. Okay. So every treatment may have side effects. So don't believe someone who tells you this treatment has got no side effects. So you've got to question the doctor if he's saying there's no side effects. But what we have to ask is what is the severity? Some treatments have very mild side effects and patients recover pretty quickly, and some treatments may have more long-lasting side effects. So when it comes to radiation therapy, there are two broad classes we can have, which is short-term side effects and long-term side effects. Short-term side effects are common, but the severity varies from patient to patient, but they usually recover after we finish the treatment. Whereas longer-term side effects may only occur months or years after treatment. These are rare, and by rare I usually mean less than 3% chance. But if they occur, sometimes they can be quite long-lasting. And also depends on the patient factors, and also what kind of treatment we are giving, what kind of dosage we're selecting, and also whether it's combined with chemotherapy or radiation alone. So all of these are taken into account when we counsel for side effects of the patient. Okay. So we've written some articles about how radiation can affect the brain. I won't go into this. But essentially, some of these side effects may be related to blood supply as well as injury to some of the nerve cells around where we are treating. And I've just listed, this is not to scare you, but this is just an exhaustive list. It's not universal, not to say that every patient undergoing this treatment is going to get all these side effects. I've just listed some of the more common ones. For example, in the short term, patients may have fatigue, may have headaches, hair loss, some skin changes, may have some mild nausea and vomiting. And in the longer term, depending on how much we treat, where we treat, there can be some changes in memory and concentration, Patients may get cataracts, as we see in the second photo here. And very rarely we can see scarring of the brain as well in a few percentage of patients. So we have some ways to reduce the side effects, for example, which I'll go through in the following slides. We have newer techniques to reduce the dose to the scalp, so we can actually reduce hair loss for some patients. We can use some medications to reduce the nausea as well as the tiredness that some patients feel. So this is an example of what we call hair-sparing radiotherapy. So we actually define where we want to avoid basically the scalp where our hair follicles are, and we can try to reduce the dose to that area so that patients, for example, young ladies undergoing this treatment, they may be quite particular how they look during the treatment. So we try to cater to their requests as well. Okay. In terms of other side effects like changes in memory, concentration, and as well as possibilities of causing radiation scarring of the brain, I will go through some of the other newer techniques that we have. So cognition is something that we all value and we all don't want to lose as we are affected by this disease or as we undergo the treatment. And there are a few ways we can tackle cognition, but generally it's multifactorial. It's not one thing that affects cognition. There's many, many things that can lead to it. But when it comes to treatment, let's talk about some of the things that we can do. So there are some medications we can use. And this is a study showing that, if you take a tablet, which is usually used in patients with like Alzheimer's or dementia, the impact on memory can be reduced as you're undergoing radiation. And we also have advanced RT techniques. So this is actually, hippocampus is a part of the brain, and it's actually a Latin word which means seahorse, because it looks like a seahorse. So this is the real seahorse, and this is the hippocampus within the brain, and it looks like this within the brain itself. And it's a very important structure which helps us consolidate our memory and also for spatial navigation. So if we can selectively reduce the dose to this structure, we can actually reduce the impact to cognition for patients undergoing treatment. And we can do this by advanced techniques. We can actually use what we call arc therapy. We can actually sterilize the other parts of the brain, but you can see the heat color map, the area that is spared is actually where the hippocampus is, and we can try to reduce the dose there. Okay, you all probably heard of proton beam therapy. So it's something that has come on newly to our shores. We do have one national center and 2 private centers offering this service now. And currently the ministry has got some restrictions of which patients can be on this kind of treatment. But let me just explain this treatment for those of you who are not familiar with it. So it's another form of radiation. So instead of using X-rays, we use particles to treat the tumor. It's still an external beam treatment, so which means no scalpels, non-invasive. But the main difference between X-rays and protons is that it's got a finite range. I mean, it's got a range, it's got a path of which it will travel, and following which there's actually a stoppage of the beam. Whereas radiation is actually a gradual tail off of the beam, as you see in this picture here. Okay, so how we deliver this proton beam therapy is what we call pencil beam scanning. So we use magnets to deliver this small spot, and we try to paint where we need to treat using the magnets. The evidence of the studies comparing proton to conventional treatment are still ongoing, but at least on paper, when we compare 2 dose plans, we know that proton therapy can spare certain parts of the brain to a better level compared to normal treatment. And this may be more relevant for patients with a longer prognosis. For long survivors who can survive 5-10 years, you want to preserve their function as long as possible. Okay, the other way we can actually preserve cognition is choosing to be focal. That means choosing a very small area of treatment where we can. And this is particularly useful in benign tumors like certain meningiomas, certain schwannomas that we see near the ear nerve, and also brain metastasis. Because when the tumor is very well defined, we can actually limit the area that we're treating, and we can spare most of the brain. And there are many ways that we can deliver this treatment. So one is called the linear accelerator-based treatment, called the Variant H, which we have at NCIS. And the other ways as well, which is gamma knife, which we also have access to, and also the cyber knife. So we don't have this in Singapore, but certain gliomas, certain brain tumors, we can actually introduce a Trojan horse into the tumor and expose, and the effect of this boron capture neutron therapy is only where this medication goes to, and it homes into the tumor. So it's particularly useful for recurrent tumors. Okay. The last part is actually quite exciting. It's something that we have been involved in the last couple of years. So the brain is like a muscle. So the more you use it, the better it becomes. So we need to train our brain just like how we lift weights and lift dumbbells. Okay. So this is Prof. Dean Ho. So he's the head of the N=1 Institute. And essentially what he did was he actually had access to some of the apps that the astronauts use, the NASA astronauts use to train their brain. And we adapted those apps to put it into a tablet to actually use it for patients with dementia. And actually we found that helpful. It can actually replace a pill. Just play a game on your phone or iPad, and that is a way of training up your brain. So we adopted this to patients undergoing treatment as well. So we actually give them post-treatment, give them an app to use at home. They actually do a few tasks, a few hours a day, and we actually assess them along the way to show that their cognition is being preserved. So this trial is just completed. We are analyzing the results and we'll publish this shortly. But I just want to end off with what we can do to empower patients. You know, everyone should be interested in their own health. Besides the medical team, we are very heartened to see when patients ask us, what else can I do to help myself? So definitely, I think exercise helps. And it helps because it improves the blood flow to the brain. If you have better nutrients, more oxygen going to the brain, your brain's going to function better, your memory's going to function better. Sleep as well, get quality sleep, try to reduce device usage towards the end of the day, try to get good quality sleep, and that also affects how well your brain functions the following day. Having a clean diet, non-processed food, trying to get nutrients up into your brain is useful. Clearly, for a healthy lifestyle, try to avoid smoking, avoid excessive alcohol. Meditation and mindfulness may be helpful, but the evidence is still not that strong yet. But generally, I think for general health, it's useful. And lastly, brain gymming. Make friends, socialize, do crosswords, do Sudoku. All of these actually helps to train up your brain, and I think will preserve the cognitive function better. So besides, Wikipedia or forums which are unregulated, I think there are some resources which are helpful for patients to go to, and these, I believe, are better because these are actually regulated and the information that is put on is sort of sieved through by medical professionals. So these are some of the websites you can visit to get more information about brain cancers and brain tumors. And just as a takeaway, I just want to end with sharing that, radiotherapy has been and will be an important pillar in the management of brain tumors and brain cancer. And the technology has evolved over the last 20 years, but it's still evolving. We're still coming up with new machines and new ways to deliver this treatment. And clearly, I think we need to balance the risk and benefits. And for that, we need to have the patient in front of us. We need to discuss with the patient and put the patient's preference take into account as well. And we have ongoing clinical trials to improve the delivery of RT and mitigate side effects related to radiotherapy. And patient participation in these trials are key for us to help improve the care that we're delivering. Okay, so I'm just going to end off with this. So at the NCIS Brain and Spine Cancer Program, I think we are the A-team because how I started off with, I think we have a good set of individuals who meet often. We talk freely, we have expertise like Dr. Teo, one of the best awake neurosurgeons in Singapore. And we want the best for the patients when you work hand in hand, and we have the patients in front of us when you want to deliver treatment. Okay, with that, I'd like to end, and thank you for your attention.